Also, a friendly reminder that this is going to be an session with interpretation services. We are going to have some speakers speaking Spanish, so please feel free to bring your interpretation devices. Buenos días, mi nombre es Juan José Castillo.
Good morning. I'm Juan Jose Castillo, consultant of quality of air and health from the PAHO. For us, it's an honor for you to be with us in this session today on global perspectives on quality of air at home, exposure, impacts on health, and solutions.
Contaminación del aire continúa siendo uno de los grandes.
Air pollution continues being one of the big challenges in the world. In spite of the world progress, air contamination at home continues being a challenge to health that contributes to thousands of deaths, premature deaths a year. During this session, we are going to have a deep outlook on the scientific evidence globally and regionally, the trends of exposure, effects on health, and the effectiveness of interventions and policies for the improvement of access to clean energy at home. This is an opportunity to interact with experts and decision makers to discuss policies and strategies to reduce exposure to.
Our two keynote speakers, please introduce Dr. Ajay Pilaseretti, Assistant Professor from the School of Public Health of University of California, Berkeley. Please welcome him.
Next one. Whoop. Hello? Yeah, okay. Thanks, Juan, and thanks to the organizers for the opportunity to chat today. I'm going to talk about household air pollution exposures, and I'm going to discuss a lot of work that a bunch of people in this room have worked on, so by no means solely mine, and thanks to all of those folks in the room. So some key messages to take away here. About 3 billion people use solid fuels for cooking. Depending on which estimate you look at, that might be 2.3 billion or 3.2 billion, but somewhere in that range, a large fraction of the global population uses solid fuels for cooking. The resulting household air pollution exposures far exceed WHO guidance. Our measurements, despite decades of measurement and growing numbers of measurement, are still relatively sparse. And we have exposure reducing interventions that we know can be effective under the right circumstances, and I'll dive into each of those a little bit more. So as I said, 3 billion people use solid fuels for cooking. How do we know this? We rely primarily on data from surveys that ask about primary fuel use. So what is the main fuel you use for cooking? Now, I don't know about you all, but me, I use multiple fuels in my home for cooking, mainly gas and electricity, but occasionally charcoal or wood outdoors, right? And so by asking these simple questions about primary fuel use, we're somewhat misestimating what's going on. Energy use is complex and dynamic, and a simple question about whether you use wood as your primary fuel or dung as your primary fuel might not be quite right. Why am I mentioning that? Because we know that even occasional use of a polluting fuel like these on the screen leads to exposures that are unsafe, that exceed that WHO guidance. The resulting household air pollution exposures are quite high, and this is some data from the Global Burden of Disease exercise. The black line is the global average, and then the regional lines are the slightly darker ones. The top is Sub-Saharan Africa, then South Asia, then Latin America and the Caribbean, and so on and so forth. The red line is the WHO interim target 1 guideline value of 35 micrograms per cubic meter. So you can see that for many regions around the world, they were historically above that level, and they continue to be. Global mean HAP exposures are about 84 micrograms per cubic meter above ambient levels, with substantial regional heterogeneity, around 140 micrograms per cubic meter above ambient in South Asia and 260 over ambient in Sub-Saharan Africa. And this is brand new modeled data from the Global Burden of Disease folks, came out on March 18th. Again, showing some, using some fairly sophisticated models to show that exposures are high everywhere. Now, about that sort of measurement sparsity, there are 390 summary estimates that are included in these models. And those are from 76 studies in 47 countries, and only about 100 of those summary estimates are personal exposure samples. And so the remainder are indoor kitchen concentrations, which then have to be adjusted down to exposure. So while we know much more than we did a decade ago, 2 decades ago about what people are exposed to. Need to slow down for interpretation. I speak quickly, I apologize. I will try to slow down. While we know more about what people are exposed to, N levels in kitchens, it's still relatively sparse. Another way to think about this is through WHO's Household Air Pollution Measurement Database, which contains about 11,000 measurements from places all over the world. Those are what are summarized in those 390 estimates I mentioned previously. Of those, less than 5% are below the health-based WHO interim target 1. None achieve the WHO guideline value of 5 micrograms per cubic meter. One other framing would then be that any household that's using solid fuel has a very slim chance of reaching those health-based guideline values that WHO sets. So we are making some improvements on the survey, measurement, and modeling front. Surveys, WHO has led a multi-institutional effort to create better surveys that ask more detailed questions about heating, lighting, and cooking, primary and secondary fuels, what stoves are used, et cetera. So we can get a much more nuanced understanding of what's going on. And they offer a short form and an expanded form of that questionnaire on their website, and the questions are starting to get rolled out around the world. We have better instrumentation than we did even 10 years ago, like the AST UPass here. It's about the size of a cell phone. It'll collect a gravimetric and a real-time sample. Battery runs between 24 and 48 hours. It's enabled much more measurement globally. And then we have much more sophisticated models, modeling of both the proportion of households using solid fuels and then the resulting exposures started with Kalpana's group and was since taken over by WHO and GBD, and they've become quite sophisticated. Just to wrap up, we have interventions that can reduce exposures to near background levels, but only when they're used nearly exclusively, indicating a need for policies that make clean household energy consistently affordable and available for the poor. So just having these things out on the market has not moved the needle in recent years. We see plenty of examples around the world of increased access to these technologies, but the recurrent cost of the fuel has made consistent use difficult. And so, making the fuels affordable and available for the poor can drive down the exposures. Just to wrap up with a figure from the HAPPEN trial, on the left, you see the control households, which use biomass throughout the trial, and so we have a baseline value pre-birth and post-birth. On the right, you see the intervention. Baseline looks about the same between the two arms, but you see dramatic reductions in exposure pre and post-birth. And just to say that when the intervention's provided for free and the fuel's provided for free, people will use it exclusively. So we know what works and we know how to get it out there. Thank you.
I'm going to take the liberty to offer our presentation so our interpretation team can relax a little bit. Please allow me to welcome Professor Jill Baumgartner from the Department of Epidemiology, Biostatistics, and Occupational Health of McGill University. Welcome her.
I'll start with this slide. So I'm going to start, I was tasked with presenting some information about the health impacts of household air pollution. So I'm going to start with my conclusions, which are that we have really extensive evidence across many types of epidemiologic studies, many settings around the world, many different populations, from infants all the way to older age populations, showing that solid fuel use harms the health of adults and children. It's supported by lots of evidence from traffic and ambient air pollution, thousands of studies at this point. And intervention is warranted even without these studies, in part just because exposures are so incredibly high, and the populations that are exposed are very vulnerable. They tend to be the farthest from healthcare, they tend to be poor, and so there's lots of factors that make them an especially vulnerable group already. So when we think about the health impacts of household air pollution, we have really strong evidence for these outcomes. Cardiovascular outcomes like ischemic heart disease, stroke, cancer, so lung cancer, as well as birth outcomes and cataracts. And you may be thinking, okay, well, I've seen studies looking at household air pollution and tuberculosis, or I've seen studies looking at neurocognitive outcomes. That's not to say that household air pollution is not a cause of those outcomes. It's just that at this point in time, there's not sufficient evidence for them to be included, like things like the global burden of disease study or the comparative risk assessment. So I'd say we have lots of compelling evidence on these, and I think we have growing evidence on many other health outcomes as well. Just to give a sense of what this looks like, so this is showing the disease burden attributable to household air pollution for low-income countries. All of the disease burden is represented here. The dark colors are the disease burden attributable to household air pollution, and the lighter colors are all other risks. And why I think this is quite compelling is if you look at things like neonatal outcomes, lower respiratory infections, you have a fifth to a quarter of disease burden that, and this is a large burden that's related to those outcomes. But then if you look at cardiovascular diseases, which we know are growing in a lot of low-income countries, it's about half of the disease burden. So this is really, really important as we're starting to think about aging populations in a lot of low-income countries. Household air pollution is only going to become more and more important for those risks. About 3 million people died from causes attributable to household air pollution in 2024, and that burden is very unequally distributed, right? So if you look at this across the globe, countries in Asia and sub-Saharan Africa are the most impacted. But it's not just the impacts that are unequally distributed, it's also the opportunities for clean energy transition. So this is looking at the population without access to electricity by region, and it's showing this over time, so between 2010 and 2022. And you see large declines in South Asia, other parts of Asia, but where it's remained relatively consistent and not really kept with population growth in the same way is in sub-Saharan Africa. And this becomes really important when we start thinking about clean energy transition, because electricity is part of that, right? So one of the most successful household energy interventions, which Professor Tao is going to talk about, recently was a clean heating policy in China that relied on electricity. It was very well liked, it was very well used. It was also built off of decades of work on electrification and recent updates to the grid. So if you're going to have lots of people transitioning to electricity, there's going to have to be lots of investment in that grid as well. So we've seen with this transition to cleaner fuels, there's been a reduction in deaths and disease burden with that. So this is some good news, which is that we've had about a 25% reduction in deaths that are attributable to household air pollution. Part of that is the transition to cleaner burning fuels. Part of that is improvements in the diagnosis and treatment of the diseases that are impacted by household air pollution. So just as one example, we've seen globally major declines in child mortality. WHO itself has shifted from survive to survive and thrive. And so the deaths that are, if looking at deaths from household air pollution, there's been a decline. I show this because I think this is quite a compelling case for the kind of positive shock to the system. So this is looking at countries that all have high proportion of solid fuel use, and they all have over 50 million people, and it's showing the decline in household air pollution attributable deaths between 2010 and 2020, so over a decade period of time. And we can see in some places, just with development happening, there's been some reduction. So we're looking at 10, 11, 12% reduction in Pakistan, Philippines, and Mexico. But then you have these countries where there's been really enormous reduction in the disease burden attributable to household air pollution. And that reduction is in large part, in many of these places, attributable to these kind of positive shocks, big policies that have gone into place and really pushed things forward in places like China and India that have really invested in clean energy. And so for some of these places that are a bit behind in that clean energy transition, there's going to need to be supports to sort of push that transition faster. So I'll move this to the panel, but just to quickly conclude, I think, we have really good evidence of very strong impacts of health from household air pollution. transition is already happening around the world, and there's going to be a need to have, for some of these places that are not moving as quickly with development as others, I think these kind of positive shocks to the system and interventions are really important. Thank you.
Well, thank you so much for those presentations. We're going to go to the second part of this session, which includes a panel of additional experts in this area of household energy and household air pollution. So if I might invite the panelists to come forward. You have their complete bios, of course, in the materials for the conference, but but we're going to start with Allison Lee. Let me just mention she's an associate professor of pulmonary medicine in sleep medicine at the Icahn School at Mount Sinai. Allison will be followed by Kalpana Balakrishna, of course, Dean of Research and a professor at Sri Ramachandra Institute for Higher Education and Research in Chennai. We'll go then to James Matari, Senior Research Fellow at KEMRI in Kenya. James will be followed by Xu Zhao, a professor at the College of Urban and Environmental Sciences at Peking. And then we'll close with Mauricio Andres Padma Orozco, who's the Deputy Director of Hydrocarbons Mining and Energy Planning at here in Colombia. So if we could start, there will be a little bit of time for questions, I think, at the end. But Allison, if you'd like to begin.
Thank you very much, and thank you to the organizers for the invitation to speak on behalf of the GRAFS team. I was asked to specifically focus on sustained health impacts that we're observing within our study. And so this is just a schematic demonstrating our study design. So GRAFS was a cluster randomized stove intervention wherein we recruited pregnant women and randomized them to either an LPG or an improved biomass stove or control. And that intervention was sustained through the first year of life. And we've now been funded to longitudinally follow this cohort. Our funding currently exists to around age 13 to 14, and our children are now about 10 to 11 years old. And so with this study design, it enables us to understand how a stove intervention and also how randomized reductions in air pollution exposure, both occurring within critical windows of development, may influence longer-term health. And we think that this is especially important because we know from extensive medical literature that healthy children make healthier adults. And in fact, that NCD risk really does begin in early childhood, and children who have poor lung health or poor cardiovascular health are at increased risk for the subsequent development of both chronic respiratory disease and cardiovascular disease. And so first, looking at lung function, at age 4, we measured lung function using oscillometry. And I'll draw your attention to the X5 and R5 to 20, where we see that children who were born to mothers that had been randomized to the LPG arm have a more positive X5 and a more negative R5 to 20, suggesting better small airway function. And this is critical because in the early life origins of COPD, we believe that these developmental processes begin in the small airways. We've also looked at exposure response functions, and apologies here, the confidence intervals are not showing up, But we've looked at exposure response functions over pregnancy using distributive lag models and identify that higher exposures in pregnancy, specifically late gestation, are associated with a more negative X5 and a more positive R5 to 20. So in other words, children who have higher exposures prenatally have worse small airway function measurable at age 4. So the opposite of what we're seeing with the LPG intervention. We've also looked at cardiovascular health, measuring blood pressure in our children. This is blood pressure measurements at age 4 years. And here what we identify is that children who were born to mothers in the LPG arm have a reduction in diastolic blood pressure as compared to control, and a trend for a reduction in systolic blood pressure as compared to control. And then when we look at sex stratified analyses, we see in fact that females may have a larger effect. Similar story here, we're looking at exposure response analyses, identifying again that higher exposure in late gestation is associated with higher both systolic and diastolic blood pressure. So again, the opposite of what we see in our LPG arm. This is work by Dr. Saram Kali, who has made the observation that there are a number of children in our cohort that even in early childhood already have elevated blood pressure meeting criteria for prehypertension. And so when we look at longitudinal blood pressure data, again, over early childhood through age 8 to 9 years, what we see, in fact, is that children who were born in that LPG arm appear to have a reduced risk for elevated blood pressure in early childhood. That effect appears to wear off over time, perhaps with subsequent early childhood exposures. And I just want to make a quick comment. A lot of our work so far has focused on how the prenatal period or early childhood is really critical for programming child health, but it's also important to think about maternal health. We know that conditions in pregnancy, exposures in pregnancy, for example, the development of preeclampsia, may subsequently influence cardiovascular disease risk in women. And so we've taken that approach here and identify that, again, women who had been randomized in the LPG arm appear to have better cardiovascular health, lower blood pressure as compared to control. And this is through 8 years of follow-up. And again, with the observation that the effect may be wearing off in time. And so just to summarize the evidence within graphs, we do identify that our LPG intervention was able to reduce air pollution exposures during this critical window of development. And our longitudinal cohort follow-up has allowed us to examine whether that stove intervention, again, during a critical period, is able to result in sustained health benefits, not only for children, but also for mothers. Thank you.
Hi, good afternoon. So Alison mentioned about the GRAFS trial where essentially the focus has been the long-term, follow-up of up to 10 years. So I'm going to talk about the HAPPEN trial that was actually led by two of the PIs of the HAPPEN trial are here, Tom Klassen and Bill Checkley. So the household air pollution trial was premised out of the fact that even, I think up until the GRAFS trial was rolled out, we still were in a position to sort of think that maybe improved coke stoves should form the battery of interventions for household air pollution. And by the time the HAPPEN trial was launched, we centered our intervention exclusively on LPG use across 4 countries, Rwanda, Peru, Guatemala, and India. Those were the sites. And the premise was that by comparing an LPG stove and continuous free fuel intervention with standard cooking practices, typically a biomass fuel use, the HAPPEN trial was really aimed to provide an estimate of a potentially achievable, reduction in the HAP exposures and the associated impacts just on select maternal, infant, and adult health outcomes. So the primary outcomes were birth weight, child pneumonia, child growth and development, and adult blood pressure amongst the enrolled households. So just like the GRAFS trial, we had a similar sample size, I think, but just that we were performing this in 4 countries. So we, I'm sorry if the legend is a little light, we essentially enrolled 800 pregnant women and and followed up the index child of these women for 1 year after randomization, or 1 year after birth, and we also enrolled a subset of older adult women in these households for following up these outcomes. We measured personal exposures to PM2.5, black carbon, and carbon monoxide using the types of devices that Ajay mentioned, and also did similar measurements on older adult women as well as on pregnant women. Essentially, one of the most striking results of the HAPPEN trial that I wanted to sort of emphasize on is, contrary to what we feared, that the LPG may not be taken up or the LPG might not be used constantly, and we might have to sort of, deal with, low fidelity and adherence to an intervention of the kind that we had not implemented across 4 countries. When the economic barriers seem to have not been there, we found essentially more than 90% or upwards of even 95% in all the 4 countries. LPG, when provided free, and of course supported by the trial in terms of support for delivery and other challenges, as well, was used almost exclusively by the households. And because it was used almost exclusively, we achieved the exposure reductions that Ajay shared the picture of at baseline, and in the control and the intervention arm were well above the WHO interim target guidelines, and we consistently achieved these exposure reductions for both pregnant women, older adult women, as well as for the children. Of course, for the children, we could not make the personal exposure measurements because they were infants less than 1 year old. So we ended up, relying on indirect measures of exposure reconstruction. So the key question was, having achieved the exposure reduction that we were so wanting to see, what might be the results of the intention to treat analysis on the 4 primary outcomes of the trial. And the first results here, all the primary outcome results have now been published. So the intention to treat analysis and the exposure response analysis for birth weight are shown here. The intention to treat analysis for birth weight did not find a significant difference in birth weight between those born to women who used the LPG cook stoves and those born to women who used biomass cook stoves. Although we, had achieved the exposure reduction that we had wanted to, but the exposure response was positive. The strength of the association, the exposure response, was at the lower end of the meta-analytical estimates that we have had previously for HAP and birth weight. Similar results on the intention to treat analysis for severe infant pneumonia, and I think I want to underscore the fact that this was an impact on severe infant pneumonia and does not include other kinds of impacts that we might be sort of relating to in this field, and ditto results for infant stunting as well. So I want to conclude here saying that the HAPPEN trial successfully demonstrate the ability of a free LPG fuel and stuff to reduce exposures, unlike anything that has ever been achieved before in the HAP trials. And the removal of the economic barrier was key for seamless adoption and sustainable use. The intervention, however, did not deliver the health benefits as intended in the short term underscore. HAPPEN 2, just like GRAFS 2 and 3, is following up children until 5 years of age currently, and we hope to do so for the 10 or the 13 that might be possible, to determine if early life interventions in the susceptible periods can result in delayed gains. And even if they are delayed, they would still amount to substantial gains for adult health. And one important thing for the happen trial is to sort of really look at the biomarker repository that has been created, that is analysis is ongoing, and it can be a huge future resource for future exposomic analysis. I have put a couple of questions that will come up again for the panel discussion. Thank you again.
Yeah, I'm going to present the work of Clean Air Africa, where we are working in 5 countries, that is in Kenya, Rwanda, Uganda, Tanzania, and Cameroon. And I want to say that Clean Air Africa is a partnership of public health specialists, clinicians, researchers in those countries and the UK, where we are trying to come up with to generate research evidence that can assist the governments in those countries to support or promote the communities and institutions in shifting to use of clean fuel for the benefits of health and also climate change and the environment. To start with, we have around six research pieces of research that we are conducting in those countries. The first one is where we're evaluating the consumer finance innovation models within the population. And these consumer models include like the suppliers of LPG within the communities, but on a pay basis, pay what you can consume, as well as also provision of the pressure cookers or efficient pots. Now, among those ones, we have found that the text messages, the message that has been done, the study which has been done on text messages has been quite impactful in that reminding the households in terms of they need to use a clean fuel. This kind of practice is normally sustained throughout, just like the way mothers particularly are normally reminded to take their children to the clinic. That text message has been quite impactful among the community. The second one finding is that we have found that those efficient pots, they have reduced the cost, they have reduced also the time of cooking, and therefore people adopt them for health benefits. The second study is where we are exploring the ability of some models that are within the schools that are being promoted. These are financial models that are promoted by the commercial banks, the equity banks across those countries. But these models are actually available on loan, so that the schools normally pay after after they have been provided with those interventions. From the raw data that we have at the moment, there is you can see that slide over there, that if you look at the schools in those countries, you'll find that like the classrooms, the cooks' exposure, the learners' exposure, the school kitchens, all of them, when you look at the two health damaging pollutants, that is carbon monoxide and PM 2.5, none actually is meeting the WHO set guidelines. They are quite high at the baseline. The intervention data is yet to come, is not yet, but there is likelihood that from what we are seeing, there will be a lot of improvements after those models have been mounted in those schools. Then the third research is where we are trying to investigate hospital and community reported bans as a function of surveillance among populations that are using and clean fuel. And the data we have at the moment, at the moment, is that we are seeing high prevalence bands among those countries. Particularly Kenya, we are at 3.4% prevalence, and Uganda 20% prevalence. But again, there is some finding which is coming out very strongly that where are we getting these bans during the investigation? We are getting more severe bans from especially those people who are epileptic and those ones who are also physically disabled. Then the fourth study is where we are measuring association between fuels, household air pollution, chronic diseases, and the findings we have at the moment, we are seeing that some association, but more association is being found among the food vendors who are within the informal settlement. Then the other study is empowering. We're empowering the community own resource, and here we are dealing with the community-owned workers and also the table bankers, where we're training them through a curriculum and a manual, a well-designed manual. And the findings here are showing us that the community-owned workers, when they are trained, they are able to create quite substantial awareness. But the problem is that not all of them actually adopt because of the financial issues. That's why the second model on table banking, because these ones they have the money, they are able to adopt very quickly, utilizing those funds that they have generated through the merry-go-round. Then the sixth one, and this is the final now I'm about to finish, is where we are trying to establish a center of excellence for air pollution to sub-Saharan Africa. And this center has been established in Kenya and is serving beginning five countries, but we are seeing other countries actually utilizing the services. What are we seeing from this one? What we are seeing from this center of excellence, which has been established, we are seeing strengthened actually regional measurements of pollutants being carried out, and also calibration of low-cost monitors being taken by the center, and also support postgraduate research students who then before you to shy off from doing those studies on air pollution. But again, the center has also been able to launch the courses. One of the major courses out there at the moment is the health journalism and public health communication to create mass education within the communities, and particularly dealing with the accurate reporting. Unlike when they are not trained, they rarely carry out balanced reporting. But now, finally, what is the take-home message? Sorry, that's not mine. The take-home message from this group or audience is that I would like to ask or appeal to the governments from these sub-Saharan countries to consider supporting these scalable models, particularly the ones from the schools, which you have seen there, they are able to give very good findings, as well as those ones from the communities. Then the other one is also to support, particularly the community-owned workers, trainings, as well as also the table bankers, so that they can be able to adopt clean fuel for health benefit and also climate change. And finally, of course, is the countries, those countries actually utilize or make use of the newly established center of excellence in terms of doing their measurements, in terms of training their journalists and their personnel who are dealing with the air pollution, climate change, and energy. I think that is all what I have. Thank you.
Yeah, good afternoon, and pleasure to be here, to be invited. I was asked to talk about the clean heating. It's a very different story compared with the clean cooking. Well, over China, over the last 20 years or 30 years, and there's a rapid transition for the clean cooking. It's not invented by government, it's spontaneously, because they improve the living conditions. And clean heating is very very different story. And we see the major energy used for the heating in northern China is using solid fuels. And we did see the change in the fuel types. Mainly it's from the transition from the biomass to coal. That's the first step of the energy ladder. And also the increase in the electricity using for the heating. Then we look at the details. The increase in electricity is not because people shift from the solid fuel to electricity, because of the expansion of the heating population. In the middle China, people usually don't do the heating. And when they get rich, they start to heat their home, use electricity for maybe 1 or 2 weeks only. So we didn't see any real transition in China for clean heating before the 1997, and the government launched a program that put lots of money into it, and it was started from the northern China, to show that the green area. It's a small area in whole China. However, they cover 75 million rural population, and the target is to replace 60% of rural households with a clean heating using either electricity or natural gas. And of course, it's very effective. It's done already. Actually, the goal finally reached is 75% of the clean heating. And we evaluated the result of this, and we see that both reduction in the ambient and indoor air PM2.5 concentrations, and especially in the indoor air, the concentration reduced more than half. So the compound the consequences, this is a reduced exposure, definitely exposure more than 60% of reduction exposure for the rural households. And of course, we try to figure out how much cost for this whole thing, and we calculate everything, start from the infrastructure to the equipment to the operation, use the energy, and we found that's a very interesting thing. Is natural gas is more expensive for this kind of thing, and but still, then more than half the rural households choose the natural gas. The reason is the first investment, initial investment, is lower, choosing the natural gas. And you find that the poor area, they like the natural gas because of the low the initial investment. But actually, it's, in the long run, they cost much more. And so we think the electricity is be the future choice, and also because of safety, because of the energy security, et cetera, et cetera. And then after this campaign, the government tried to push this all over the northern China. And how to do this? They say, okay, we'd like to have 40% of the clean heating in northern China. So of course, it's going to be very, very expensive. So we try to figure out, set up a called scheme, and based on the initial investment for the infrastructure for the electricity. So I'm not going to detail of technology things, and actually we divided lots of small clusters, and to calculate the cost for each cluster. And the idea is that we start from the most populated area that will be relatively cheaper per household, and then we expand this to the whole country. And how much the government like to input into it, then we can look at this diagram. So if you have more money to investigate, and you have the reduced cost effectiveness. So they have to look at it, go to a certain point. For example, I'll give an example here. If we put the 8,000 Chinese yuan per household for the infrastructure, then we can cover almost the 70, 80% of the northern China using clean heating. So the following this the strategy, the government can, okay, we have a certain amount of money, we can invest it to a certain area, in one step or next one, and we go to the certain places. Okay, that's the talk. Thank you. Thank you very much.
Hi, everyone.
Hola.
I'm going to present the National Firewood Substitution Plan for Colombia. However, I apologize, I'm going to do it in Spanish, so sorry for that. However, the presentation is in English. Okay, bueno, entonces...
Well, Colombia, with the energy sector, has taken this national firewood substitution plan, which is known as the Kin Cooking, in which we have been able to develop an energy transition that takes migration towards other fuels that are cleaner. We have developed this considering the GPL, natural gas. We have considered biogas and biomethane, considering that Colombia has a great potential in terms of biomass, renewable biomass, and it can benefit from these resources. And finally, we have electricity given the circumstances, geographical circumstances of our country. So, however, we from Colombia have addressed not only from the energy sector, but also something which is cross-sectional that takes us to climate change, health, even air quality. In this way, here we have a map, a Colombian map, in which you are going to see what are the yellow regions and red regions, in which in the left-hand graph, we have basically regions in Colombia where fuels, renewable fuels, are used in greater proportion when we see the green areas. I mean, the middle of the country. The most vulnerable areas, which are the yellow and red areas, are basically the ones that use fuels that are non-renewable fuels. In the right side graph, we are going to have fuels that are more polluted. These regions, the rural areas in Colombia, and the most vulnerable regions in terms of public service accesses, and also in terms of safety and in terms of lives, fuels. And therefore, this plan has been developed aiming a methodology not only to have the energy sector, but also transport sector, road sector, air quality sector, what we are seeing here. Some time ago, our panel colleagues have shown results and outcomes on a country level. Here we are starting this process. We have some pilot tests that have been done here in Colombia. However, what somehow complicates in terms of a national aspect is the access to those regions due to geographical reasons. You were saying about energy transition for us. Reaching the Amazon region, which has to cross rivers, jungle, forest, the lowest part of Colombia, the Amazon region, the limit with Peru and Brazil, reaching these grids, it's really complex in terms of expanding those grids. So this is why we have designed a plan that goes step by step. We have short, medium, and long targets to obtain this goal. Currently in Colombia, we have that natural gas is the most important energy for household use, followed by natural gas. But this has something that when we are going to see the factors in terms of use of pollutant fuels, basically in this case wood, we are going to see that it's affecting women and children in terms of these households where they live, what are the conditions of women and children. They are the ones that dedicate in Colombia to collect all that wood inputs for cooking, and additional to this, those who use and are in the households cooking with this fuel. So we have a public health issue with children and women. We had seen it before. These are data for Colombia. And basically, this is a problem that we have. However, we need to consider that modifying energy fuels is not simply creating a great impact in terms of emissions for household cooking, but yes, in terms of health and air quality indoor. In those indoor households. So now we have here within the plan included the costs of each one of those kits of technologies that would migrate to these goals in terms of the goals for 2026, 2030, and 2050. We are going to be migrating from LGP, natural gas, in terms of biomass, biomethane, and finally electricity. Basically, these are the solutions for substitution that cross-sectional we've started to understand that to aim and obtain this substitution, we can migrate towards the climate change, air quality, and diseases as well. Thank you so much.
Well, many thanks to the panel. They've shared a lot of really interesting information, and I think we want to give you a chance to raise some questions. But if you don't mind, maybe I'll start with a few. And I didn't really introduce myself. Tom Clausen from Emory University, and I am a trialist. So I have, as some of these panelists know, so I tend to attach a great weight to an RCT, a randomized trial type of study design. And maybe I want to start by asking Allison, and maybe Kalpana would have some thoughts on this. Like, are you in some ways surprised by some of the results that we're seeing? No protective effects on the primary outcomes, but then we're beginning to see some effects kind of longer term. So where do you regard that as leaving us in terms of the research on interventions? The mic's on. Okay. There it goes.
Aha, okay. Yeah, thanks, Tom. I mean, it's a great question. I think, one thing that I want to point out is that not everybody is susceptible to air pollution exposure. So for example, if we look at the tobacco literature, we know that not everybody who smokes is going to go on to develop COPD or is going to go on to develop lung cancer. But yet that doesn't, we still believe that there's a causal relationship between tobacco smoke and subsequent disease. And so I think that, one potential avenue for the science to move forward is to really try to think about susceptibility, to try to understand susceptibility, whether that's genetic susceptibility or whether that's the presence of comorbid diseases, and other factors that may influence whether you have a stronger health response to those exposures. So I think there's a lot that we can do with our existing studies to think about that. But I also want to reiterate a point that you made during your opening keynote, and that Jill made as well. Because we do see differing effects, or we don't see an intention to treat response with birth weight, that doesn't negate all of the supporting evidence that we have for the harms of air pollution on health. We know that air pollution is bad. We know that air pollution harms health. And in fact, from these studies, both HAPPEN and GRAFS, we see that there is a stove intervention that's able to significantly reduce air pollution exposures. And so I hope that we can perhaps focus on that as a critical policy outcome from these studies. I think the science can sort of inform perhaps tailoring of public health policy. Clearly, we want to reduce exposures over the life course, but maybe starting out targeting sensitive windows, young children, pregnant persons, elderly. Perhaps we can have a staggered approach where our end goal is the reduction of air pollution and clean cooking really across the life course. But perhaps there's still policy implications from some of these results.
Well, thank you, Alison. You covered it all, I think. And I just wanted to say, I mean, this is, I will say that when we all started the trial, we were pretty convinced that we will see effects in the short term because we had a lot of information going into the trial that the exposure reductions are going to be in the best part of the exposure response spectrum, and therefore, it was very likely, but we were hoping that. But when you look back and think, at least I will speak for India, if you look at the communities that we chose to intervene on, these are communities that have huge things going wrong for them for maternal and child outcomes. These are not communities in which wash has been taken care of. Many are. Yes, the randomization just, of course, balances it all out from a study design point of view, but what kind of susceptibilities or what kind of trajectories are these population already on that our intervention cannot reverse in the short term is an unanswered scientific question. So I think that we should sort of really focus on the epigenetic part of it or the exposomic part of it going forward, even if we do decide to do a randomized control trial. But the other challenge is, how expensive is it to sort of really continue an RCT for the amount of time that would be needed to sort of reverse or for that matter, even prospectively induce positive health effects. So the big lesson learned from the Happen trial, of course, is that it's really important to do very good exposure measurements to sort of really set ourselves up for exposure response, but also prove that it is possible to achieve health relevant exposure reductions. Number two is to sort of really look at how RCTs of the future might be co-supported by governmental initiatives to actually maintain the interventions to sort of convert the RCT into an observatory of sorts, wherein these natural experiments also provide us with enough power if there were to be co-support. I don't think research agencies are in a position to sort of really continue the trials for the lengths of time that from a biological point of view we might want to say. And the last thing I'm going to say is that we're hoping that in Happen, we still see beneficial effects. Critical window interventions matter. And if we were to see that in Happen, that would be sort of a great point to so corroborate what the graphs is already finding. So we are looking at graphs and hopeful that we will find benefits for having intervened, even if those benefits were not visible to us in the short term. Thanks.
Yeah, thanks. And I maybe should emphasize for those of you who are a little bit familiar or unfamiliar with this area, is that much of the effort prior to these particular trials was trying to improve stove efficiency, and to continue on biomass. And that was found, much to the great credit of the late Kirk Smith, that is not going to get the job done. Virtually none of those stoves were able to achieve the levels of reduction that would be necessary in order to achieve health gains. That was really the motivation for running some of these trials that really made an effort to try clean fuels. And LPG, of course, was the most scalable of those options. But there are other obstacles to actually getting to a point where we can make sure that these very vulnerable populations have the benefit of clean fuels. And one of those is behavioral. So, and for those of you who have been working on some of the other applications, maybe James, have you observed that overcoming some of the resistance, the behavioral resistance to shifting to a different type of cooking has been a major obstacle?
Yeah, thank you very much. Yeah, it's not only across the 5 countries where we are working. that resistance has been there. And one of the resistance in terms of shifting to clean cooking is where the communities tend to say that the food, when it is cooked with the new modern technologies and the fuel, it doesn't taste well the way it tastes when they are using their own traditional fuels and the cooking pots. But then we have mounted some standards in Tanzania, that is in Tanzania, and this standard, when we did those standards, we cooked different meals, but the people who are to taste, we brought in different people to taste who are not a part of the cooks, so that they tell us whether this food which is cooked using which using gas, the other one using LPG, and the one which is cooked using the normal firewood and the charcoal and their normal pots, whether it's different. And I can assure you the results were very interesting because they could not differentiate what kind of fuel was used or the pot, and that's a breakthrough actually, especially from such standards. And maybe the others is like cost, because in the previous section I heard about the cost of the technology. Sometimes the communities say no, it's very expensive to afford actually LPG because it's more expensive than charcoal, it's more expensive than kerosene. But one study we did actually in Kenya in one of the informal settlements, we found that using LPG through actually what you normally call pay as you go through smart meters, just like the way you use electricity for the tokens, we found that gas was cheaper, 50%, 40% cheaper than kerosene, and 30% cheaper than charcoal. The truth is that when they are buying LPG in cylinders, it's very expensive at once. But when they are buying charcoals in small kilograms, small portions, and the kerosene, they think it is cheap, but it is not cheap. It's only that they are buying in small portions. So that kind of resistance has always been there, but it has to be actually brought down by a specific research, and then you share with the communities.
Thanks.
Yeah, and the communities sometimes they don't look at actually the preventive aspect of it. They immediately benefit. They start thinking about it is expensive. This is also more. I mean, it's a foreign technology that is being brought. So I think behavior change has to be a continuous process, not where one has to give up, but it has to be backed, of course, with the research, and then there must be also champions who are really respected out in the communities to deliver the point to them when you are actually disseminating these findings.
Got it. True.
Okay, may I add one sample? And once I went to the Zhejiang province, there's a very rich province in China, the rural area, the one old man there, they cook the meal using biomass. And it's a very big house and very well equipped, the kitchen, everything, electricity, LPG, everything, but she's still using biomass. And I think that's kind of it's a behavior. It's nothing to do with cost anymore. And people talking about the risk of communication, talking about the education, but it's a very, very difficult thing. And to let the older woman to understand, I shouldn't use this, I should use the clean one. And I think I have to wait for the next generation. It's not optimistic, and it's difficult to educate the people to shift their behavior. So it's not necessarily the cost.
May I ask, Mauricio, what are you finding to be the major obstacles to adopting the cleaner? You have an actual ongoing program, right?
Okay, yes. Well, we have the same problem that in Africa, yes, where there is a cultural taste for the Colombian plates. So we have found that in first place. But about the national firewood plant substitution, we have a vision that is give the households in Colombia an alternative for cooking. That's what the plant is the main vision. It's not about the substitution, is giving the country, the households, an alternative for cooking. Okay, that's the first. And the second one is that, well, we started this plan in 2022, 2023, and we started going to the territories, to the regions. At the beginning, they will not understand what we are talking about, mine and energy. This is the entity where I came from. So we started to do it a different way, like talking about the benefits in health, the impacts in women and children, and the benefits of the subproducts that can be they can be useful for the territories to cooking and generate energy. That's the two.
Thanks for that. And thanks for raising this question about looking at these other benefits, because in a forum like this, of course, we're primarily focused on delivering these health benefits. But I think some of you have talked about some of the other benefits, and sometimes we've tried to quantify those in economic terms. And I know Graphs has done more of that than others, but do you, or I know Darby's here too, and maybe can speak to some of the economic issues around that trial. Would you care to? I want to involve the audience here a little bit, right?
Yeah, as a pulmonologist, I'll pass this to the economist.
Yeah, so I guess the first thing I'd say, I think the young gentleman here asked in the last session, is there anything that's clean and affordable? And unfortunately, the answer, I think, is no, just an unequivocal no. So that's a really important point. I think a second really important point is that for a tranche of users, a tranche of consumers, this point that James made that people are paying about as much for charcoal as they are paying, as they would need to pay for LPG, is critical. So that's a real window of opportunity. But the folks who are using wood fuels in most of the world are not paying for them. It's free, right? And it's very hard to compete with free. Even if it's cleaner, and I love the anecdote about the blind taste test. I think that's beautiful. Even if there's not even if the food tastes the same, it's just very hard to compete with free. And so so one thing, and there's been a number of technologies that have been, or a couple of technologies that have been tried to basically overcome the liquidity constraint. So a key feature of LPG is you have to purchase a full cylinder, and it requires saving up. It requires that households save over the course of a month and then transact. And there's a pay-as-you-go technology, which is a regulator that sits on top of the cylinder. The fundamental challenge with that is the cost of goods of the regulator is quite high, and so that technology has had real challenges with scale. It's basically been unable to scale without donor support. In Ghana, we're trying a digital payment system, so a dedicated LPG wallet that lives on a mobile phone, mobile payment system, with sort of points rewards for frequent small deposits that basically mimic the frequent small transactions that James described that charcoal users are typically engaged in. So I think this is an area to really work on, to really explore, to try to figure out how to overcome these liquidity constraints for folks who are currently using charcoal. I think for folks who are currently collecting fuel wood for free, it's really got to be subsidies or else wait for economic growth. And neither of those are very attractive options. I mean, how many of you are going to go to your government and convince them to subsidize LPG? I mean, the countries that have had experience with that, it's been huge. Ecuador Ecuador has done this since 2001, and it's $700 million a year, give or take. So it's a massive fiscal commitment, and for a relatively small population. Peru has a strong program. But it's really challenging to subsidize. But I think that's really the only policy tool that we have in our quiver at present.
Thanks. Yeah. If others have questions, just identify yourself. Let me ask one other question before, if you may. So the people keep talking about, well, why are we spending these resources and burning another fossil fuel? And one thing I don't know if I heard from any of the panel members today is, well, what about climate? Does these types of interventions have anything to do with climate? And I have a view on that. That yes, I'm all for electricity. I would electrify everything. But these issues about having this population bear the burden of trying to reduce the fractional contribution that shifting to LPG, for example, is making to climate is just unjust. So that is one perspective. I understand there are others. If we could shift right away to renewably sourced electricity, and I think we should do everything we can. But in terms of climate, I don't think that should be the leading argument when it comes to household energy. There's some questions. Go ahead.
Yes, hi. Stephanie Montero from the Clean Air Institute. So, well, two questions. The first one has to do with like the multi-sectoral approach, especially, for example, in Colombia. Have you worked together with the health sector, the environmental sector, maybe the Department on Gender and so on to approach these communities? That would be the first one. And the other one, there's a recent success story or pilot in Guatemala where they thought not only on changing technology, but also how to save or how to increase time savings, for women. So in Guatemala and Central America and Mexico, we have tortillas, wheat tortillas, and that has been very difficult, because there's no electric alternative for tortilla making. So they ask women to stop making tortillas and buying them instead of buying firewood, and just use electric appliances at home and buy their tortillas from tortilla vendors. And they believe that one of the main factors that of a very successful adoption, it was, I think, almost 90% of women still use their electric appliances, and more than 90% still buy tortillas, was time savings. It was like almost 3 hours a day that women saved. So I believe it's culture and how the food tastes, but I think if we give the opportunity to these women, to imagine and experience another reality, just give them the chance, not just go there and try and change the technologies and so on. Just give them the opportunity for a few months to try out and see what happens. I think that's another rationality or perspective to approach the project. Thank you.
Thanks so much for that comment. It's so great to hear about some of those success stories, and there's a lot of benefits in terms of time saving, and some of those are quantified. Some of those aren't touched on very much. One of the things that isn't touched on enough is the empowerment of giving alternative energy to a household, and that's mainly women's empowerment. Go ahead. Oh, sorry, we have a. Go.
Yes, it's just she asked for the example of Colombia, and yes, we are doing that, and that's the reason why we are here right now, because of the Well, when we published the National Firewood Substitution Plan, we recommended in that document the creation of a technical table where, we come from the energy sector and we don't have anything to do from the health sector. So we recommended the creation of a technical table where everybody can come. And right now we are sessioned like 6 times from the 2023. And in this table, there are 10 members, which are the Minister of Mining and Energy, is the leading ministry. We are from the Ministry of Mining and Energy, but they also are the health sector, the household sector, environmental sector, planation, and Department of Planation of Colombia is also there for money. We have we have 10 members of all kinds of sectors in Colombia. We were come to understand that this is not only the energy sector, you show everything, but we are actually cooperation for these objectives of substitution of firewood, of the clean cooking.
Thank you. We have time for maybe 1 or 2 more comments, questions.
Thank you, and congratulations for that work. Intersectorial is very important, and I think that is one of the main opportunities we have been talking about in this meeting. So that's the first step, I think. I want to get back like the equity lens that we were talking yesterday in our PAHO meeting. And I think if we want one solution to fit all, that is not working, and we are leaving out precisely those that will not be able to adopt and use LPG. If we want all to use LPG, I think that is a problem, and we should be tailoring the intervention also for the population. We should be asking what they need for their cooking practices and look the other agendas, because when we look to the nutrition, the diet, we are talking about the traditional diets are good, they are healthy, and they are sustainable. So I don't think we want to change the diet from many of these populations. And so I think the intervention should be much more local context adapted, and don't expect all to be adapting to LPG cooking. And I think we also have to think about more innovation with biomass. There are many places where biomass is free, available, and can be a renewable fuel. So we really should go back and don't lose that opportunities for innovation, because there can be some good uses. Because if that population, you give them LPG, but they don't use it, they will have an open fire, and then the exposure will be the same. So you are leaving them behind, because you are not giving them an option that is cleaner, and they have to rely on the open fire.
Thanks for really emphasizing that equity issue and the need for innovation. Well, okay. What? Sorry. We might go a little bit long, but you are invited to leave when you need to, right?
Thank you very much. My name is Alan Bigelow, and I'm the Program and Science Director at Solar Cookers International. I'm also a solar cook. It's something that I do in my personal life on sunny days. And so solar cooking is an integrative solution to be added to what is already there. And find this very interesting, the discussion from the stage, but also from the audience. This is fantastic. What we do is we primarily work with collaborators and apply best practices. You mentioned that you work with some champions in East Africa, local women perhaps. That's an excellent way to help with the behavior change and to establish trust and transmission of knowledge. So congratulations for that. We find that that works also very well in a project in North Kenya, at a refugee camp, Kakuma refugee camp, where we often hear tamu sana, for that the food tastes sweet. And so we are also experiencing that the taste is basically the same with the solar box ovens that we're using. I want to point out one thing, that there's at the Health&Energy, there's a roadmap on clean cooking that was published just recently. And it says that in order to get to the targets for clean cooking for all, renewable energy cooking methods have to be included. So I encourage those of us who are working on clean cooking projects to at least include some renewable energy-based cooking systems. And with that, where's our economist heading? I want to challenge you on free fuel. That with us, we have found that with our data collection, that in fact the solar thermal cooker, if it's adopted at the rates where through best practices, it's actually used widely among this particular population in the refugee camp, where they are not allowed to go outside the camp and look for free fuel. So this is a particular context. They would have to pay for the fuel, and so the usage of a free fuel oven, solar oven, it can pay for itself within about a year or two, depending on the model. Lastly, I do have, I need some clarification on the study that was presented today between biomass and LPG. And I'm not a medical professional, I'm a physicist. And I hear that the exposure has decreased when you transition to LPG. When I see the graphs, I see that there's still exposure, but the particle size has shifted. And with that, I have concerns, and I need to understand this more. What happens when the particle size decreases, but those who are using those cooking methods are still being exposed to the smaller particulates? And if it's leading toward some health challenges as well, this sounds like something we need to understand better. So if there's any questions for answers for why, I would really
suggest that maybe you come up and get those answers from the experts up here. I'm told that we really need to wrap this up, but many thanks for all the work that you're doing in solar cooking, something that it's a bit of an orphan in this business sometimes, but can make a contribution. Yeah, no, go ahead.
I just want to make one quick comment to that, because within graphs, we did have an improved biomass stove arm where we did not see a significant reduction in exposure. But in fact, in our subsequent follow-up, we have seen some evidence that perhaps children who had been, their mothers were in that improved biomass arm, that they may have worse health than control. And we're concerned because this was a fan-assisted stove, and perhaps it is a shift in particle distribution. So, and this is a very small arm. This needs to be replicated, but they do have worse lung function than our control arm, for example, at age 4. So I think it's a valid concern.
Great. Well, many thanks to the panelists. I think, Ajay's initial slide really hits the key points here. We know how to reduce exposure. We know that we're talking about a massive population of 3 billion, and we know they're the hardest to reach of this vulnerable population. And we're going to need really innovative solutions. And while, this is kind of a statement against interest, I don't know if we need a lot of more RCTs. I'm not going to be quoted by my friends. I don't know if we need a lot more RCTs to answer some of these fundamental questions. I think we know how to reduce exposures. I think we know exposures are associated with adverse outcomes. And what we really now need is some of the policy people to step in and say, okay, and that, of course, is a major major intent of this session. So, okay, it looks like we have a couple of comments. I'm totally fine staying around, but if you need to run, please do. Will?
Devil's advocate.
Mm-hmm.
All right, so yes, Will Checkley, physician scientist and a pen and paper epidemiologist, but I wanted to push back on that idea. Do we need more RCTs? So I think we all here believe that air pollution is bad, and we know that it's bad, and we believe in that alternative hypotheses. But to be able to help policy and move policy forward, we need to have good evidence to show that interventions do work. And the best way to do that is RCTs. How can we provide evidence to governments to invest in interventions if we do not show that the interventions work? So I think this is a big challenge. And so again, coming back to, I also believe what Allison says. I think there's a lot of gene by environment interactions. So what are the calls for action? Is it larger trials? Is it targeted populations? And I think these are the answers that we should be able to, as a community, provide and create that roadmap for either the people here in the room or for future researchers to go ahead and answer. Because I still think, and I still think that we do need to provide the evidence to help governments say, yes, I'm going to invest in this.
Right.
And I think that's a big challenge.
Yeah, it's a fair point. I hope people don't leave here with the idea that say these interventions don't work. These interventions reduce an adverse exposure that is associated with important health outcomes. They may not be enough, and we're not even sure if governments need additional evidence on this. The barriers to government policy is sometimes short of knowledge, although that's the business that we tend to be in. So we need to really understand what drives policy here. One more last question or comment. Two more.
Okay, so I just wanted to say, especially because we're here at this Global Air Pollution and Health Conference, we know that this is a huge public health problem. What we see here is, in fact, we have the evidence, we have an implementation challenge, we have a policy challenge, but I just wanted to reflect on the fact that in all of my years working on household energy as one leading source of pollution, but also thinking about transport, construction, all of the other leading sources that we have to deal with, I have never, we're all very caring, thoughtful, committed people. I have never heard anybody working on transportation pollution saying, you know what, maybe we shouldn't really focus on this because it's very expensive and there are other sources of pollution that we may not be able to cover and address. They take this problem, they take this leading source, and they focus on it.
Even without a trial.
Yes, yes. And so I sometimes feel like maybe we're overly cautious and overly careful. And if we're here because it's a public health issue, then we need to also address it as a public health challenge. So any concerns that we may have about cost or about, thinking about different things, there are definitely approaches that can be taken. And I think sometimes we're just becoming too difficult, saying on the one hand, this is a development challenge, so we hope that somehow it will go away by itself. Obviously, that hasn't happened. And then on the flip side, we'll say, well, but it's so expensive, we're not able to do this. There's certainly work that can be done over the next 5 or 10 years where billions of people could actually get access. There are also people who are going to be really difficult to reach, and we have to remain committed to seeing how we can help to transition them, but we shouldn't get stuck by always thinking about the extreme examples and then not thinking in more practical terms about just how to advance the issue.
Thanks, Sumi. I think, can we wrap it up there? I'm really getting a, thanks so much for attending, and thanks so much for your contributions. This is one of the biggest challenges in air pollution, so it really demands all of our attention, all of our best efforts. Thank you. Oh, right. Yeah, I want to thank the interpreters who stuck around with us, too. Thanks, guys.